Great.
All right. Caitlin, you want me to go ahead and introduce Essence?
That would be great.
Awesome, terrific. Well, it is such a joy and an honor to be able to introduce Essence Hairston, who has, I think, more titles than anyone else I know. She is an LCSW, she's an LCAS, she also has her supervision licensure, she almost has her PhD. She's our outpatient program manager for UNC Horizons Wake, the director of community engagement and integrated treatment services. She's a clinical instructor in the Department of OBGYN for UNC at Chapel Hill and the project director for perinatal and maternal substance use disorder treatment reentry services. And Essence today is going to tell us about a paper that we published that was truly a work of love and honoring a former patient of ours. And so, Essence, go ahead and take it away.
Awesome. Thank you, Caitlin and Andre and everyone that's here. Again, I'm Essence. I am privileged and honored to lead this amazing reentry and recovery work focused on women leaving carceral settings. So, like Andre mentioned, I'm going to discuss with you about some services that we provided during the COVID-19 pandemic while managing the opioid epidemic, caring for perinatal women with substance use disorders leaving prisons. This brief report was published by the Journal of Addiction Medicine. So I'm sure you all are familiar with Horizons, but for those of you who are not, so the UNC Horizons program is basically this comprehensive substance use disorder treatment program. We provide services across the continuum of treatment services, all the way from residential, which one of the highest levels of care, to prevention and outpatient, so one of the lowest levels of cares, as well as our reentry services, our gender responsive reentry services. Our primary goal is to reduce fatal overdoses for our reentry services, recidivism, and also we want to keep the dyad together, so avoiding separation due to reentry. And although our primary focus is treating substance use disorders, we also know that we have to treat the PTSD, recognize the violence, and also the environment in which people come from. And once we do all of that, we then want to share that information out to the world. So whether it's through training, as Andre mentioned, clinical supervisors, we have fellows that rotate our clinics, and then also publications. So we're going to talk a little bit about Jenna's project, and you may think of like four things you're going to talk about today. I promise you it's all interconnected in the Jenna's project. I'm going to keep us very streamlined. I really love this work, and so I'm going to have Andre and Caitlin tell me to, okay, that's enough, because I will talk about this all day. So the Jenna's project, we received funding in 2019 from the Ford Foundation to honor Jenna. Jenna was a former Horizons graduate at our residential programs. And for some reason, Jenna made a decision to return back to her home county. Of course, that's my bias when I say for some reasons. There's a lot of reasons why people want to reconnect to their community and their homes. But unfortunately, Jenna got reconnected to people, places, and things that often led to use or return to use in the past. Because of those reconnections, Jenna accrued new drug-related charges and was imprisoned as an outcome. At the time of Jenna's hearing through court, she had reconnected with one of our peer support specialists at Horizons, who was actually there to provide care coordination and advocacy for another person in our program at the time. And Jenna wrote a note to give to our peer support specialist. And that note basically asked, I need help. Can I get back into Horizons? Of course, our wonderful peer support specialist turned that into our senior therapist. that same day. And what I will say is during that exchange of Jenna asking for help, Jenna also had access to prescription pills on her at the time of court, which was actually given to her by a person who had sold drugs who was also at court that day. And so our peer support specialist came back to Horizons, talked to the senior therapist who could assist Jenna with returning to care. But unfortunately, within 24 hours, Jenna experienced a fatal overdose. Um, I think this project one allows me to say this was actually a preventable death. And we'll talk a little bit more about those outcomes and why I feel so strongly about that. But Jenna was an amazing mother of four. She had this like laughter and kindness and such a gentle soul. And again, I could talk about her all day. But one of the things that, out of the many lessons that we learned from Jenna, is that what are we missing? What are we missing to address perinatal opioid use disorders, and how can we expand our reach to this population? Thankful for four, we were able to do a 2-year pilot providing comprehensive substance use disorder treatment for individuals, for perinatal individuals for up to 6 months. Our primary goals were to care for 50 perinatal women living with an opioid use disorders and leaving prisons. Um, we had some really good outcomes, as you can see, and I say primary outcomes because we had so much more than what we imagined because of the success of this project. So we started off working with one women's prisons in North Carolina, and by the time of the program completion or project completion, we were actually connected with another state prison, Anson Correctional, and we were actually forced to work closely with 40 jails because of this legal processing known as safekeeping, which I won't go too in detail about that, but it's just the involuntary movement of a pregnant person, including pregnant person or women with a substance use disorders, to a prison because their jails are not equipped to care for them. And then we had some connections with a federal prison in Carswell, Texas. So we were able to provide care for individuals leaving one prison, but then word of mouth is like amazing. We were like expanded across state lines and to provide support for some folks that were returning back to the North Carolina area. We were able to reduce perinatal incarceration by intervening at the jails. In terms of safekeeping, those are oftentimes individuals who have not yet been convicted of a new crime. And so we were able to get individuals into treatment as part of conditions. Instead of caring for 50, we managed to care for 132 unduplicated pregnant and postpartum people. We had a 1.5% return to illicit substances, 0% of opioid-related deaths or injuries, also 0% of non-fatal overdoses, and we define non-fatal overdoses as any overdose that will require Narcan or any type of care through emergency setting or hospitalization. And then we had a 2% reincarcerated rate. And if you're like me, I'm a perfectionist. I'm always looking like 1.5%, 2%. What? What happened? But anecdotally, what I can do, because we remember those who that's the where we need to fill in the gap or those trends. And what I can anecdotally say that the individuals in that criteria unfortunately had a separation with their children that could not allow them to enter a PPW program. And they actually got connected to another program. And then the reincarcerated rate was also for probation violation due to not being able to pay their probation fees as well. So, anywho, that's not in the publications, but it's something that we took away because always want to know what happened. Where can we improve? We provided again some wraparound comprehensive substance use services for 6 months. We gathered information at intake as well as a 6-month follow up with Also, some in between data entry points at 3 months. Because individuals in North Carolina are more likely to experience a fatal overdose, 40 times more likely to experience a fatal overdose. In our state, we also looked at overdose rates at the time of 2 weeks. We were providing in-person and telehealth substance use counseling, immediate access to medications for opioid use disorders and other psychotropic medications, immediate transportation to treatment, whether we were providing the transportation or organizing transportation with probation and parole officers or other entities to ensure individuals were able to make a smooth transition to care. We also added a legal consultant, which is a former judge from Orange County who did a lot of work with family drug treatment courts. And then also we did QA and QI. So we wanted to assess the fidelity of the evidence-based practices we were providing. So therapy, case management, transportation and childcare, making sure that we can promote uh, retention, I guess, or engagement, sorry, for care during that time. And then we actually transitioned from an interdisciplinary team to having this transdisciplinary team, which honestly is really a fancy way of things that we're already doing. I just like to say transdisciplinary because it makes it sound like cooler, if I'm being honest. But it's really just strengthening the communities and the villages that we have. And so one of the things with Jenna's project, again, the primary focus was case management, connecting individuals to OUD in therapy. But we really started seeing success when we started creating the village as service provider. So that housing specialist, the legal consultant, networking with maternal child interventions or providers as well. And so what we learned that gender responsive reentry and recovery services can actually reduce fatal and non-fatal overdoses among perinatal women living with an OUD. We had by I think the success, or not, I think I know that the success was based off of meeting the unique needs of perinatal women. Because all of our participants were self-referred for services, meaning that we didn't actually have to actively go out and recruit. Everybody who wanted to be a part of Jenna's project, they came, and everybody who wanted to be a part of Jenna's project was self-referred to us. So their autonomy, their choice to choose us was super important. Increasing access to recovery and social support at the time of reentry, again, can reduce reincarceration just based off of that 2% of return to incarceration, as well as we were partnering with our pregnant and parenting women's programs. So we call them PPWs. And so by nature, we were able to enhance those recovery social supports for the women that also reinforce recovery behaviors. And then also gender-specific services can increase access to OUD treatment at the time of reentry. So the Genesis Project, we saw a 51% increase in access to medication for opioid use disorder compared to 39% at intake. I mean, geez, especially for individuals leaving prisons, again, thinking about that 2 weeks where they're so vulnerable and at risk for fatal overdose. We also learned that more than 90% have at least one child under 18. So, although we were working with the perinatal population, we also knew that individuals were caregivers for other children as well. And then also, we saw anecdotally this need to increase reentry services for women of color. And that was something, a trend that we started to take heed of. And one of the things that in the work we started seeing, like, what is happening? We know there's a disproportionate rate of Black and Brown individuals being incarcerated. And one of the things that we also learn is that white women, as well as women of color, are actually incarcerated at the same rate. The difference is that Black and Latin, including women from tribal communities, are more likely to face harsher sentencing or longer sentencing. So it was very difficult for us to help with conditions to reduce that perinatal incarceration, but also being able to say, oh, okay, we know this population exists. What are we missing? What are we doing? And so Jenna's project allowed us to see how can we increase access for women of color. So what we learned and what we did with that information. So one, we realized that we cannot change a system that we're not a part of. So we wanted to connect more closely with the North Carolina Department of Adult Correction. So we have colleagues in their social work program, the OBGYN program, psychiatry, as well as their perinatal case managers. They also have their own in-house substance use disorder treatment program, where I'm so excited that they use a Stephanie Covington manual. So they're also utilizing evidence-based practices in gender responsive curriculums for women with substance use disorders. We were able to create, and I would say the very first, I have been called out on this many times, but I'll tell you why I call it the very first perinatal sudden incarceration housing program that really focus on addressing the racial and social inequities among perinatal women. Again, we have our Oxford House models, and they do accept perinatal women and women and children leaving incarceration. It's a wonderful therapeutic community. But one of the things that we've been able to do with the help actually of Andre, we submitted this like brief proposal, and it wasn't even an RFP. We just said, let's just do it and send it to Wake County uh, and see what happens. And we were fortunate enough to be successful and get funded, but it is a fully furnished apartment at no cost for individuals. All they have to do is meet criteria for a substance use disorder, as well as needing housing or unhoused, and their goal to reconnect with their children. So we have five fully furnished apartments with one apartment dedicated to an on-site manager. We were recently informed that we will be able to expand our housing program called Cherish, where we will be able to work with 30 families doing a voucher-based model. So based off of the success in one of our Orange County sites where they were providing actually cash to landlords for individuals. They've seen success rates with that. And so thinking about transitional housing, and when we think about transitional housing, we're thinking about also transitions for children and infants. And so being able for individuals to identify their housing of choice and to reduce um, uh, moving throughout and maintain that stability is significantly important. And we also expanded our reach. So we did not forget about any female identified person or a person who just actually like, you know what, I don't desire to become pregnant or have children, but I do have an opioid use disorder and I am in the state of North Carolina. What about me? And we said, we hear you. So we expanded our reentry services to three state women's prisons here in North Carolina. So we have with actually three unique different models in terms of interaction and pre-release services. So we are providing comprehensive reentry and recovery services for the three state prisons here in North Carolina. Very different from our 50 participant milestone in Jenna's project. But hey, we can do it, right? And so our primary milestones include 400 participants. And again, we want to avoid fatal overdoses and reduce recidivism. We see that funding by a DHHS, the opioid settlement funds. And we are actually close to getting our 400 milestone. And if you are near wood or even fake wood or vinyl, like plank wood flooring, please knock on wherever there's near to you. As of today, we have not had any fatal or non-fatal overdoses. to date for Empower. Again, this like statewide project. So working with women across the continuum, so not just the perinatal population, and then we were also able to leverage the success of Jenna's project to hone in on co-occurring diagnosis and disorders. So for us in our care, we see co-occurring often all the time. So we know that someone's going to have a substance use disorder. When we're thinking about trauma-informed care, we know that trauma is going to exist, or maybe a PTSD diagnosis, as well as depression. But we also have a little bit of a tiny room and space to care for individuals living with a severe, persistent mental illness. But again, we do have a village to help support us to do this work. And so we also providing comprehensive care coordination and getting individuals connected to care based off of the ASAM risk rating. So looking at the sub piece, but then also the locus where we're looking at substance use disorders as well as mental health placement in terms of care. Our primary milestones, again, another 400 participants. We want to avoid substance use related overdose. Again, reduce incarceration, also reduce psychiatric hospitalizations due to co-occurring diagnosis. And ultimately, we want to improve the quality of life, right? When we think about addiction and recovery, it's lifelong. When I think about reentry, it's lifelong. Like someone that's entering into a carceral setting, that is going to shift their trajectory for the rest of their lives. Like it is, I've never been incarcerated. I have, well, by choice, I've been to the prison, of course, but have the privilege to, walk out. And I can tell you, even leaving a prison, I always have to be like, what is around me? What can I see? What can I feel? Because of just the environment in itself, not the people in the environment, but just the structure of being surrounded by individuals with rifles and right. And so, but anywho, another 400 participants, again, working with one prison. So this is not our statewide prison. We're focusing on one prison, which is actually the largest state prison in the state. We want to say, okay, Jenna's project, you did this one prison. We actually want to go back home and stay right back in Wake County and provide reentry services in that county. And then we were recently awarded the ROS project. Elizabeth Johnson is the project director here, and we are integrating our substance use disorder treatment within two family drug treatment courts. It is a significant need in terms of working and providing care for women involved in the legal systems. Actually, there's limited research on women and family drug treatment course. And what we do know in terms of family drug treatment course is that women are more likely to be referred and connect to care, but they're least likely to actually graduate from family drug treatment courts. And so one of the things that we learn is that this parallel between reentry and recovery treatment, addiction treatment was created for male identified people. Prisons and the legal system were created for male identified people. So we're seeing these gaps for when women at the intersection of both justice involvement as well as women and substance use disorders. And that's also fairly funded by SAMHSA. Here's Andrea Canato. So one of the things again that we do at those QA and QI, we see, how can we strengthen care, but also how can we create a continuity of care where there's really like a hot handoff or a warm handoff to services, and it's a smooth process and individuals are connected along the way. And so with the success of the Jenna's project, we were able to see being embedded into a prison and connecting with individuals also could help with navigating those releases as well as reunification. So here is Andrea Caneto. She is a OB/GYN doc at UNC, and she's also the director of incarcerated health. So she oversees the OB and GYN clinic at the women's prison. in North Carolina. And the cool thing about this is that we were able to utilize Dr. Elizabeth Johnson's clinic. So she has a prenatal postnatal integrated clinic model, and really just say, see if this works in the prison. And it was very successful. We had a 98% return to substance use disorder counseling. So individuals can access their medications for OUD without having that counseling requirement. And so individuals were actually really wanting care, like we know, right? People want to get into treatment and care. And as far as we know, it is the first integrated prenatal subclinic in a women's prison for sure here in North Carolina. But we have not heard of any other integrated prenatal subclinics where individuals can have that integrated care in a prison setting, just as someone would outside of a carceral setting. And so that is all that I have. I know I just gave you so much information of like, wait, the Jenna's project, 132, and then we just went to 400. So I know I just provided you with a ton of information. Um, but so if you have any questions, and I saw the chat come through, happy to also answer questions in the chat. But it's been an awarding and amazing project as we continue to find meaning for Jenna. And it started with one person, and now being able to provide care throughout the state, including co-occurring, including increasing that continuum of care. So it started off as reentry services, and that increased to prenatal subclinic, as well as to some pre-release services, all the way to reentry for 6 months to care treatment as well as housing. So really going through the recovery process with them. So I'm going to stop sharing and stop talking because again, I will continue to talk if there's silence. And yeah, I will defer to Andre and Caitlin on questions, or please feel free to open up the chat as well.
Thank you, Essence. It's great being able to hear about all this amazing work. And I'm so glad that you also get this published and out into the literature to share your positive findings with others. So we'll open it up for questions. Please feel free to put them in the chat or unmute. I'll go ahead and get started by reading one from the chat from Camila about are there interactions between the different programs that you are discussing, or are they totally separate? And Camila, I'll let you follow up too if you have any follow-up questions for Essence on that.
Yeah, let me try to answer, and then if you're like, no, you didn't answer the question at hand, please tell me, and I will definitely revisit that. So we started off with the Genesis project. So we facilitated that from March 2020 to October 2021. And that was specifically focused on the perinatal in OUD. So perinatal women living with an opioid use disorder, and it could have been a mild, moderate, or severe, and also other polysubstance, but they had to had a opioid use disorder. And so we finished that project, but because of our the success of that project and those outcomes, we were then able to provide additional services, so expand our reach. So there are different programs, different services, but they're so interconnected with each other in meeting the needs of the populations leaving prisons here in the state, but also based off of what we learned from the Jenna's project. So it's almost like the meaning that we had is an agency to address perinatal overdoses for folks leaving prisons. We kind of just expanded that over time from what we learned with the Jenna's project. So we're all one program, we're all Horizons. It's just the services just look a little bit differently, but it started off with the Jenna's project.
It's all under Horizons, but is it like separate teams? I'm just trying to imagine, or is it like different people might be on multiple teams that I'm trying to understand sort of how it all fits together.
Oh, yes. No, that is a really good question. So, yes, we have our Empower team. So we actually have someone that is physically housed in Buncombe County. We have someone in Anson, which is the Mecklenburg, so Charlotte area. So we actually have for our statewide project, we have individuals who are connected with those prisons and I don't want to say assigned, but dedicated to serving those prisons. And then we have our co-occurring team. And so that's our GRACE project, and we have a different team for that because there's another level of expertise needed when working with, and I don't want to say co-occurring, but maybe someone living with a severe, persistent like mental illness. So it's a different team that's providing care for that, but also recognizing that the cool thing about this is that someone can receive therapy from Empower, but their case management is for Grace. So we do want to share the burden and the care based off of need, and if individuals what their needs are, what their treatment plans are, and also what the teams can provide at the time. But yes, each team and each project has its own dedicated team. For Jenna's project, it was about 4 or 5 of us at the time providing care. And then four, if you include me for Empower, 4 for Grace, because I'm behavioral health by nature, and I love to work with individuals and do case management. It's like the most rewarding thing. And so we have about 4 to 5 per team. Our RISE project, that will also be peer support led. That will also have 4 or 5 behavioral health staff. Mhm. Good question.
Great. What other questions do people have? You feel free to unmute yourself or place it in the chat.
Hi, Essence. I just had a quick question about how people are accessing the services. So I know that you said y'all are going into the jails and initiating contact and doing intakes, but is that for everyone? And then once people are released, if they've heard about your programs, they can reach out and begin at that point?
Yeah, it's a really good question. Leanne, I actually try to stay from the term jails because it gets so complicated, but I think you make a really good point of when I'm like the carceral setting, and that actually can mean both jails and prison. So to answer your question, these services are specifically like prison based or like reentry from a prison. However, because for our perinatal women, they could be physically at the prison, but administratively on paper, technically, supposed to be in the county jail. And we do receive referrals. We are fortunate enough to have a 30-year history of Horizons. So honestly, when people hear Horizons, they actually think of residential, and then we're like, oh, you can get residential, but you have to. Sorry, we're not the residential team, but we can connect you with the residential team. But to answer your question, anybody can refer to us, whether it's a jail or prison. For our prison-based like reentry service, they had to have stepped foot in the prison at some point to receive services. But we can provide bless you screenings, assessments, intakes. We definitely want to look at that pre-release, ensuring that we can get folks connected to care. The case managers, providers have sent referrals, DAs have sent us referrals, judges have reached out to us for care. So it's a little bit of both, where we do get some referrals for jails. And even if they're not prison-based, we do have a colleague, Andrea Caneto. She's doing some jail-based reentry work. So it's not to confuse anybody, but it's another project that's connected to Horizons, but is really focused on perinatal SUD in jails. And so they are doing a lot of referral screenings and intakes and getting individuals to PPW programs. But yeah, so yes, we do. We can go into a jail, we can go into a prison. to do referrals and assessments. And we also can do a telehealth as well. So we do a lot of like telehealth or hybrid assessments at prisons.
Can you talk about the process that you guys have followed to get access, like to get into the prisons and get into the jails? I know those are two very different processes.
Mm.
We've tried to do some of that. I'm in Indiana. We've been more successful, I think, in working with the jails and getting into the jails and doing like telemedicine and prescribing into the jails. But I'm less familiar with when we have Indiana Women's Prison that has a nursery, but it's much harder to get into the prison system, I find. But I don't know if it's the same in North Carolina. I'm just curious what the process you followed was.
Yeah, that's a really good question. Hmm. It's really hard because I don't think I have like a formal protocol. I think that's also probably why I have so many like titles, because of like the community engagement. It's just like I just really want to work with communities. And then the integrated treatment services is like, if I see where we can augment your services, I'm gonna plug in some perinatal substance use disorder treatment services. So with that being said, Andrea Canetto, she is actually an OB doc in the women's prison. And so what we did was like we just leverage of like what was the need? Like people need prenatal care, especially as we're looking at maternal mortality. We're seeing overdoses and suicide as the main two leading cause of deaths among this population. And so during the pandemic, all of the programs were being pushed out of the prisons. And so we leverage with Andrea Canetto, but also with other like the warden and other social work programs who actually share the same mission and values. So if Indiana has a prison, and please take this with a grain of salt, because again, I'm the type of person that in order for me to help facilitate change, I feel like I have to be in it. So recognizing that it may be a little bit different, but seeing like who's in the leadership of the Department of Adult Corrections in that state, and just marketing and telling them about services. And honestly, if I could be completely honest, tell them it's free. Like, you don't have to do anything. Like, we receive this funding to help you. And look at this amazing thing that your prison can actually say, unfortunately, that they're providing. And it does not, add any burden to your team and your colleagues. And we're going to honor and respect your protocol and how you want things to like facilitate. So we are fortunate enough to start with Andrea Canetto, the OB department, but we expanded to our social work programs and the ACD programs. And it was one of those things that we found our people and who wanted to strengthen continuity of care outside of that prenatal clinic, because that's typically once a day, but those social work programs, the alcohol and chemical dependency programs, they are there throughout the week. So just finding our people within those settings, because they definitely exist, and then connecting that way. So all that being said, I would say probably identify even the warden or the assistant warden, or if there are some like perinatal case managers or someone in that nursery that you may know, because you really only need one person to kind of start with the referral. So no formal process, but one of the things that we've learned was just seeing who's all here at the table, who's like running the show, who has a little bit of power and privilege. What is it that this prison need and want? Can we feel that need and want? And so everybody's needs are being addressed. The prison is not having to navigate, substance use disorders at the time of release, and not have to figure out where are we going to take individuals. Individuals get equitable care, and access to care as they would outside of a carceral setting. And then our programs get to evaluate that and to take it to funders and say, hey, this works, we need additional funding, but kind of starting off to see um, who all shares the same mission and values, um, and go from there. 'Cause I will say in North Carolina, everybody's goal is the same. No one wants a pregnant person in the jail or prison. Like, no one wants so the way to get to that goal is very different. We'll say substance use disorder treatment. The jail may say, I'm gonna take you to the prison, right? But overall, the goal is to not to have this population. And when I say jails and prisons, it's very different to the folks who are mandating, who's giving sentencing to for folks to go to jails. But so yeah, you just connecting with individuals who have the same care because honestly, the goals are the same even though we have different disciplines.
Since you started to kind of get on, the question I had was about sustainability of your project and going forward. I'm just curious about that plan if you have one. And also um, from a research perspective, how did you guys choose the measures and your plan and your protocol for the QA QI aspect of your project, so you could then share that with others who might need the data, right, the numbers in order to do their own thing back home and convince the local county, right, to give them funding or yeah.
Yeah, I will say for the latter part of your question, I feel like there's some things that I think we can add to, just like the Jenna's project in terms of, because when I think about QA, QI, because we're like evaluation BA, like, so I'm more so looking at it from like a behavioral health perspective and quality improvement, quality assurance, like what are the clients are saying? What is the treatment saying? Their needs, like, are we actually providing true care coordination and case management, looking at satisfaction surveys, and things like that. Um, I think, and I'll tell you the reason why I'm thinking about this is because we actually did not find any difference. And Andre, please could correct me if I'm wrong in terms of like CPS status, even though I know anecdotally that is very different. But again, in terms of just trust and provider trust as well. In terms of sustainability, I feel like as soon as you get a grant, you're already trying to find another one. It's, it's also like, again, that's like a whole position in itself. And if you're providers, whether it's like medical or behavioral health, you're doing clinical work, you're writing, you're leading teams, and it's like a lot of stuff that's happening. But one of the things that's happening here in North Carolina is the expansion of Medicaid in jails and prisons. I think for the most part, all of the states are should be transitioning into that. So I do think in terms of the funds secure for this population. There could be some dollars there. I know we are leveraging the opioid settlement funds, and so here in North Carolina, we have received some funds to, if we wanted to reapply for about 15 to 16 years. So after our 5 year projects through SAMHSA, wanting to probably leverage those state funding to uh, maintain like sustainability. So to answer your question, so for the pre-release services, so for the assessments, identifying ASAM placement, getting people connected to the right level of care, leveraging the expansion of Medicaid in carceral settings, which there's some pros and cons to that. But again, I'm going to save that for a different discussion. And then also for reentry, I know there's also some models for like tailored care management plans too. That's with LME and MCO and partner with those. But then also just leveraging the opioid settlement uh, dollars for the next few years. And Andre, did you have anything to add about the evaluation and like the QA, QI, and then like our outcomes to add to that?
Yeah, no, I mean, I think we approached it, we wanted to be as simple as possible and figure out what the services were that we were actually providing that we
Mhm.
thought we would see differences in,
Mhm.
and just being as laser focused as possible.
Yeah,
So,
for
and I
sure.
agree with the Child Protective Service outcomes. I think that, we only follow people for 6 months. 6 months is a short time frame in the
Mhm.
world of Child Protective Services. So
Yeah.
I think if we, had followed for 12 months or 18 months, certainly
Mhm.
24 months, I think you'd start to see more
Mhm.
of a separation. But yeah, or more better outcomes, put it that way. So
Are
yeah.
you guys still following? I mean, you guys still getting more data or no? Okay.
Not systematically. We weren't funded to do that. So we basically expanded to be able to do the 400. But we would love to
Mhm.
have a project where we could, because I think that's one of the big criticisms. Well, you only follow people for 6 months,
Mhm.
which that's pretty daggone hard to do, right? But then everybody wants to know, well, what happened to 12 months? What happened to 24 months? So to
Mhm.
have a randomized trial, which I think would be, a logical extension of this evaluation work would be great. How
Right.
you define what usual care is an ethical tricky wicket, to say the least, but I think that's sort of the next logical step.
Well, that is an exciting next logical step. Well, what other questions do people have for Essence today?
I don't know if this was part of your project, but something we're really interested in here is, um, since we have had a lot of our maternal mortality review committee has seen a lot of deaths of people who've left prison. But
Mhm.
we've been thinking about different things. Of course, this would be fantastic, but you do need funding. So one smaller thing that we've been trying to think about is even just making sure everyone who leaves prison has naloxone.
Mhm.
But also like has been trained because we're finding a lot of people have it, but nobody has really explained to them how to use it or like talk to their partner about
Mhm.
it. So I mean, fortunately, you guys haven't had any overdoses, but I'm really curious if part of this project, when you're preparing them to leave, is to talk about that. Um, and then another question that I have is at many of conferences you go to, they talk about Vivitrol or long-acting naltrexone as a thing that reduces overdoses when people leave. We don't have a lot of luck with people wanting to do that. Of course, if they're pregnant, uh, not initiating that. But some of these individuals, they're postpartum, so it could be an option. So those are two questions. You may not have time to answer it. But I was just curious if either of those are interventions that are, I know that's not that medications are not the focus of this, but if those are things that are been discussed or looked at within your project as well.
Yes and yes. So our ladies get care packages that include a Narcan and naloxone and like a little like education sheet. And then we also do provide some psychoeducation on how to well again, I'm behavioral health, so I'm always like before you actually pick up the substance. So there's a psychoeducation piece there, but then also discussing, the outcomes of using alone and connection and also carrying naloxone. So individuals, we do provide these care packages for them at the time of release that will include that. And then also in terms of MOUD autonomy, so we do support any um, route or any of medication that the client decide. Fortunate for me, I am not a medical provider, so I do not know all of the ins and outs of naltrexone and pregnancy and opioid use. But I do know that our providers, or I'll consult with even Andre and Elizabeth to say, hey, there's this person who actually wants to do naltrexone or Sublocade or Suboxone. Most of our women that we serve, we do have individuals access Suboxone, and then also methadone. It just depends on like stabilization and also where they are at the time of delivery. Because unfortunately, here in North Carolina, as soon as someone delivers, they're like tapered off of their medication for opioid use disorders. And That is horrible anyway, but in prisons, they only get that dose once a day. And so oftentimes what we're seeing individuals, I don't want to say high dose because I think when I say high dose, it makes it sound like very bad, like people should be at a lower dose or a medium dose, but we're seeing I guess higher doses in terms of like MOUD. Again, I'm not a medical provider, but I'm typically outside of carceral settings. I'm used to seeing like maybe 18 milligrams or 24 milligrams at the max. And individuals in carceral settings are actually prescribed maybe 34, 36 milligrams, 170 milligrams of methadone. And so as soon as they deliver, they only have 2 weeks to taper off of that. And on top of just like hormones, on top of just delivering a human being, like an infant, just all of the things that's happening. And so one of the things that we provide psychoeducation to is one, ensuring that people have access to care, access of their choice, in that continuity of care. And so making sure we actually, if people want to be on substances that they, I mean, sorry, people who want to be on medication for opioid use disorders, that they are like immediately connected for the sake of both mom and in the infant. But yeah, so we don't provide it, but we have providers as part of the team, psychiatry, family medicine, that can do a lot of the MOUD, telehealth, and in person. I see. Yeah. Kaylin, how long do you know when the taper starts? Do you see is 2 weeks like?
We work mainly with, we don't have a relationship with our prisons here, but with many of the local jails we do. It's everyone does their own thing.
Mm-hmm.
Every single one. Leanne just popped off, but she works with me. And we have a very good relationship with one local jail where the program that she works with has been able to kind of do a smaller version of what you're saying. We started small with our integrated medical substance use treatment clinic, and then through our collaborations with Leanne's group, been able to add on layers. And one of the most recent layers has been our sheriff now being pro MUOD, which is great. And so verbally, recently she told us that no person should have to stop their medication postpartum. I do not yet have that in writing, but I have that verbally from the sheriff. So we know what, you start small and you work from there. Versus another local jail in Chesterfield, they have a whole grant-funded program where they do provide buprenorphine to all people if they want to be in this one specific program. And so the postpartum people can get kind of lumped into that, so they don't have to stop. But our other jails do not do that. And some of them don't collaborate with us at VCU. So everyone's different and does their own thing around here, at least in Central Virginia.
Same, that's how it is here in North Carolina. The jails, each county operate, differently, and who is in office, I'll say, at the time, or their, beliefs in terms of how to treat unmanaged substance use. But yeah, so one county will be super supportive and I'll say progressive in terms of jails, and then other counties are, just, yeah, let's take them to the prison, or, it varies for sure here as well.
Yeah.
I find it actually a little bit more complicated to interact with jails than prisons. And I don't know if it's because they all have to operate the same on the state level because there's, state prisons. But yeah, jails it's kind of a little bit harder to integrate. And so it sounds like you all are doing amazing work because again, we don't see a lot of that perinatal focus in jails. Yeah.
So I'll ask our last question, then we'll wrap up Essence. But I like Camila's question about for this postpartum discontinuation, what do you guys do in your programs to help people get back on medications, for example, if they desire to do that? I can tell you what we do, but it is very haphazard and not systematic because we don't have large scale programming. So I'll let you answer the question.
Yeah, so I'm sorry, the question is how do we help individuals get back on
They
the
get
MOU?
released, like when they get released and then they're back in charge of their own care, or like with your help, to connect with psychiatrists, nurse practitioners, etc., OBs, family medicine. Is that one of the aspects? Is that you try to help them to make to, be
Oh,
able
yes.
to start again? Okay.
Oh, yes, for this project. So we also had a 24/7 Justice Involved perinatal sud line where individuals could call, I mean, the line still exists, could call us specifically for immediate transportation to care, treatment, and access for medication for their OUD. And so what will happen if a person, let's say, was released on a Friday, of course, with no medications on the Saturday, or Sunday, of course. And let's say OTPs may only have set aside time for when they can do a new person intake. What we would do, especially for buprenorphine, I would call Elizabeth Johnson. She's our medical and executive director here at Horizons, and she would actually call in a bridge script and meet with that person either like over the phone. So we make sure she has all of the information she needs in terms of the medical record system. For methadone, because it's so highly regulated, we oftentimes have to defer to, we have an OTP that we work with in Raleigh, but if someone is going outside of that, we have to recommend individuals to go to their local emergency department, or we've also been successful with urgent cares to maintain that dosing for Saturday. They'll get a take-home dose for Sunday, and then kind of get them connected on Monday. But any other MOUD, we can get them reconnected and pay for their prescription as well.
So expensive to fix a mistake that like never should have happened, but still, I'm glad you guys are able to do that. But I liked your question too, Caitlin. Like it makes me think of, and what you said, Essence, always looking for a new grant to be able to do stuff that should be like basic
I
human
know.
care. It's just really, it's great that you're doing it. It's amazing, but it is hard to hear like all this, the rigmarole that it takes. Like we are actually having this discussion about naloxone, and all the
Mhm.
things that we do to get it to people, and they should just be like, here you go. At any pharmacy should be so easy, and we're always like borrowing from each other and doing all these crazy machinations.
I know, and it's so expensive. I was actually in Target the other day and I saw Narcan. It was like $40.
Yeah,
And
it's more than that if you try to get it through prescription. So if you try to get it at certain places, it can be like $200. And then there's all this free grant given out naloxone, but it's not getting to the right people because
exactly. Yep.
who knows where it is? I don't know. And then I tried to do a presentation in DC to give out naloxone.
Mhm.
Indiana wouldn't give it to me to take because it was another state, and DC wouldn't give it to me because it was a national conference. And so they said it's not going to DC residents. So I
Wow.
just had to like scrounge and borrow from friends. And I was like, this is the silliest thing, just trying to give people naloxone.
It is, yeah. And we
I'm
see
like,
that
go
a
to
lot.
the vending machine. And I'm like, I'm not going to sit there and take the vending machine because that's for people who need it, like in that moment. Like, that doesn't feel right.
Right.
So,
Yeah.
yeah, great project, Essence. This is really remarkable. And I got the article. I didn't have a chance to read it before today, but I'll definitely take a look at it because we're trying to expand what we do in our with our jail. Ours is very haphazard and like we just know people, and so then yeah, like they call us and we get in, but we end up having to do it like case by case each time because we don't have a grant for that aspect of our work.
Yeah, ours was actually, it started off like haphazard too. Like, I mean, nobody wanted to pick up this project. I mean, no, I mean, I can't under like hopped off, but I just remember of like this amazing project just being like, nope, nope, no, no. And it was just like, what are we supposed to do? So still doing the work, yeah, I would probably you say haphazard, but it's like still showing up in the way that we can, in the best way that we can, given these like limitations. And it just took a long time for people to see this need. And it took a private or not-for-profit organization to do so, to
No,
do.
you just this is a really important step because again, in our MMRC, we see people that had like prison-based programs, like in the prison, right? They were doing well, they were getting therapy. You see all the therapy visits and, doing really well. And then they get released and they're dead a few months later because there was no connection for when they left.
Yeah.
People overdosing like in the treatment facilities even that they got released to. So, because
Mm-hmm.
kind of just plop them in there, didn't take them, didn't do all the steps kind of. So it is this connection step is so vital, but no way to pay for it unless you have a grant. There's nobody.
Oh, for
Yeah,
sure.
you can't bill Medicaid because they're not even on Medicaid yet. So
Oh,
if you could potentially bill for some of this case man, you can't. So
you're right. Yeah. Yeah. It's tough. Yes, it's very tough and difficult. And, even for us, we see like because we are advocates and like we somewhat still impacted by the discrimination and the stigma and the bias. It's like, who's going to want to fund? So you see certain projects of what is deemed worthy, right? Like who's deemed worthy of funding? And so it's kind of even seeing it on this end of like, why is it so difficult for people to have just basic access to care and social drivers of health? And like, why do we have to piecemeal these things when we know, like the research shows this is can be successful. This saves lives. And um I'll say this one thing before we go, and I picked up a code now that I will use around medical providers. And they were like, they said, this is a code blue situation. And the light bulb that went around of like, I am going to start using that everywhere that I go. Because we, as behavioral health, everything is a crisis. Like for like we want to, everything. If somebody is crying in tears of joy, we'll say, "Oh my, is everything okay?" It's like, yes, I'm just happy tears. So, but the code blue really resonated like with me from a behavioral health perspective, but then also for just medical. But in terms of probably thinking about scaling up and thinking about integration of care and also collaborating and strengthening our reach to other like medical providers and emergency departments. Like we have a community health hospital who only have one person that will prescribe MOUD and they don't. It's a community-based hospital. So just thinking about like this is a code blue when somebody's leaving. I don't even know if that's the right thing, but I think that's universal. But I do.
it is. Yeah,
But
I mean, like I put in the chat, like the fact that they're taking people off, that's basically a death sentence. Like it's really against all the evidence. But and I also really like the fact that you guys have the different programs focusing on special populations because when we just do generic programs for everybody, it's really harmful. And I mean, I think I love this. There's like a couple of sub papers from the mother Andre's paper that looks at like, some different programs, some that specifically supported different types of populations. And it's really interesting how good the outcomes are when you provide what the people need. Like when you don't just say, well, we just have this IOP and doesn't matter what your background is, doesn't matter your gender identity, doesn't matter your racial identity or ethnic religion, like you just come and just you're gonna like this,
yeah,
and it's like, well, maybe if you have a really talented leader who just has a way of like integrating everyone, but in general, we find that that's not the case, like that you do need to have some special way of like attracting your specific population and providing them like that holding environment.
yeah,
Hard to do that. It's hard to do that, but you need to try.
attracting them and then also retaining them.
Yes, and retaining them,
Yeah,
absolutely.
for sure, for sure.
Yeah.
Yeah.
Thank you. Great presentation, great programs. So much to take in.
Thank
Thank
you,
you
Essa.
so much. Thank you.
Thank you. Bye.